Hello friends, welcome to Midlife. Today we are going to study about the axillary or circumflex nerve. So it is a major peripheral nerve of the upper limb. Now let's see its anatomical course. The axillary nerve is formed within the axilla area of the upper limb. It is a direct continuation of the posterior cord of the brachial plexus and therefore contains fibers from the C5 and C6 nerve roots. In the axilla, the axillary nerve is located posteriorly to the axillary artery and anterior to the subscapularis muscle. It exits the axilla at the inferior border of subscapularis via the quadrangular space, often accompanied by the posterior circumflex humeral artery and vein. The axillary nerve then passes medially to the surgical neck of the humerus, where it divides into three terminal branches. Number 1. Posterior terminal branch. It provides motor innervation to the posterior aspect of the deltoid muscle and teres minor. Nerve to teres minor bears a pseudoganglion. It also innervates the skin over the inferior part of the deltoid, also called as regimental batch area, as the upper lateral cutaneous nerve of the arm, which is its sensory function. Number 2. Anterior terminal branch. It winds around the surgical neck of the humerus and provides motor innervation to the anterior aspect of the deltoid muscle. It terminates with cutaneous branches to the anterior and anterolateral shoulder. Number 3. Articular branch. Supplies the glenohumeral joint. Now let's see its clinical relevance. Injury to the axillary nerve. The axillary nerve can be damaged through trauma to the proximal humerus or shoulder girdle. It often presents with other brachial plexus injuries. Common mechanisms of injury include fracture of the humeral surgical neck, shoulder dislocation, or iatrogenic injury during shoulder surgery. Motor functions. The deltoid and teres minor muscles will be affected, rendering the patient unable to abduct the affected limb beyond 15 degrees. Sensory function. The upper lateral cutaneous nerve of the arm will be affected, resulting in loss of sensation over the inferior deltoid, also known as regimental batch area. So here the blue part area is called regimental batch area. Now let's see a small video of axillary nerve and try to understand from that video.
The axillary nerve is a terminal branch of the posterior cord of the brachial plexus and derives fibers from C5 and C6. Coming to its course, it arises as a terminal branch from the posterior cord of the brachial plexus. It leaves the axilla through the quadrangular space, along with the posterior circumflex humeral artery. It gives an articular twig to the shoulder joint before dividing into anterior and posterior branches. The anterior branch continues horizontally between the deltoid and surgical neck of the humerus and supplies the deltoid. The posterior branch supplies the teres minor and the posterior part of the deltoid. This is its motor innervation. Then it pierces the deep fascia to continue as the upper lateral cutaneous nerve of the arm. It supplies the skin over the lower half of the deltoid and is its sensory innervation. Through the action of the deltoid, the nerve is responsible for shoulder abduction. However, the anterior muscle fibers cause flexion and medial rotation of the shoulder, and the posterior muscle fibers cause extension and lateral rotation of the shoulder. Through the action of the teres minor, it is responsible for lateral rotation and abduction of the shoulder. Now coming to axillary nerve injury. This causes both sensory and motor deficits. Injury is usually caused by two things: an inferior dislocation of the humeral head This is due to the fact that the axillary nerve courses inferior to the shoulder joint. A fracture of the surgical neck of the humerus. This is due to its course around the posterior aspect of the surgical neck of the humerus. Injury to the nerve will result in the following: loss of horizontal abduction from 15 to 110 degrees. This is due to paralysis of the deltoid and teres minor muscles. Atrophy of the deltoid. This may lead to loss of the rounded contour of the shoulder. And lastly, loss of sensation on the skin of the cap of the shoulder. This is due to involvement of the upper lateral cutaneous nerve of the arm.
Here are the few questions. Please try to answer them in the comment section. For the reference, I will provide the answers in the description. Now let's see question number 1. The illustration below shows a patient with long standing axillary nerve palsy. Which of the following muscles has undergone denervation atrophy? Number 1. Coracobrachialis. Number 2. Teres minor. Number 3. Deltoid. Number 4. Supraspinatus. Now question number 2. Which vessel accompanies the axillary nerve as it passes through the quadrangular space? Number 1. Brachial artery. Number 2. Anterior circumflex artery. Number 3. Posterior circumflex artery. Number 4. Axillary artery. Question number 3. A patient undergoes a shoulder arthroplasty. Post-operatively, the patient reports numbness in the distribution of the axillary nerve. Which branch of the axillary nerve is most likely to have been affected? Number 1. Anterior terminal branch. Number 2. Posterior terminal branch. Number 3. Articular branch. And number 4. Muscular branch. So here we finished about the axillary nerve. Please like, share and subscribe with your friends for more videos on anatomy. Thank you.